Dr. Muralidhar? Dr. Muralidhar, good evening.
Good evening, Dr.
Yeah,
Suresh. Can you hear me?
I'm hearing you. Thanks. Did you check the
Yeah.
slides? Thanks for accepting our invitations and thank you for
No
making
issue.
short notice there.
No issue. No issue.
Yeah.
Yeah.
Can you
It
check
was
the
short,
slides
but
are
it is
moving?
okay. I just collected some cases for PG teaching, no?
Yeah.
So
Did you check
just
the slides are like opening and moving?
I'll just upload
Ah,
it.
just check and see whether it's moving or not.
Can you see my slides now?
Yeah, now I'm seeing slides there. Good. Okay. Just move one or two slides. Yeah.
Okay, I'll just put it in slideshow.
Okay. Sure.
Yeah. Is
You
it
can keep it
moving
there
now?
because, yeah, no problem. Yeah, it's moving there. Correct. Yeah, it's fine. Good. Your voice is also clear. So the usual
Yeah.
program is we start at 7:30. Some of the APA members can join there. For example, the ICP Dean, Dr. Kamlesh Tiwari sir will join sometime. If not there, I can give a brief intro about you. And you need
Okay.
presentations for 30 to 35 minutes or even go up to 40 minutes, depends upon the interactions. Then 10 to 15 minutes of Q&A. And finally,
Sure.
I'll put a couple of questions for post-test following the presentations. What is a grasp of the knowledge there? Usually the capacity is 100 there and almost 85 to 90 students so far registered. So I circulate to some
Oh.
other GPs also. So GPs also join and people are joining late. Like sometimes some other sessions are overflow more than 100 also. So they join to the YouTube. Otherwise, like most of the time, 60 to 80 the joining capacity will be there. It depends upon once time goes there, they'll join there. So usually
Yeah.
7:35,
Oh,
7:40.
mine is only 40 minutes. I made a little bit more
No
slides. I'll
problem.
skip some of them.
No
That is
problem, sir.
fine.
No
No
issues.
problem.
Yeah, 10
I
to
thought
15
it
minutes
was for
on.
an hour, so I
Ah,
added more cases
yeah,
there.
yeah. So 10, 15 minutes of Q&A and finally I took on 7 to 8 minutes to show a couple of posters whether they grasp the knowledge from your presentations or not. That is a basic idea. So
Sure.
another 6 more minutes is there, no issues.
And this is a weekly program, is it?
Yes, weekly every Saturday we're running there, but I'm going to change to Tuesdays because Saturdays of summer month getting a faculties are slightly difficult because people are traveling and disturbing the Saturday night.
Mhm.
So I thought changing back to initially they allotted a Tuesday, but now a Saturday I find slightly difficult to get the faculties because I don't want to disturb on the weekend. So I thought of changing to Tuesdays evening there. Right now this is
Yeah.
Saturday. So far 8 session is over. First session directed by Dr.
Mm.
Professor Chandrasekhar, how to approach infectious diseases in the practice and why infectious diseases he made. Then microbiology and clinicians, what are the
Mm.
microbiological aspects? Second by Dr. Arna Pujari. Then Priscilla spoke about PUO approach. Then Dr. Tanu Singhal about antibiotics, how to select and how to choose. Then we moved into syndromic approach. Skin and soft tissue, we finished it. And last week we finished about pneumonia by Dr. Murli. And this week we are doing UTI. Next week, Arvind is doing meningitis and meningoencephalitis is doing it there. And one more gastroenteritis is planned in the syndrome will be
Sure.
over. Then we go to the sepsis part and some tropical stuffs in the third part of the thing. Usually they wanted to do 20 to 22 weeks there. And at the end of the 20 to 20 weeks, when examinations for the candidates were registered officially there. Particularly they got DNB medicines or they're doing DNB medicines or MD
Oh.
medicine. So this is by AP only. They conduct all programs. Diabetology course on Monday, and some hematology course is happening on Tuesday, but a little early.
Mm.
Wednesday has got a pulmonology part there, and
Okay.
Thursday emergency medicines. Friday, one more thing, and Saturday 2 sessions. One in the afternoon time, clinical medicine. Doctor Anupam Prakash is doing from Haynes. He's coordinating for clinical science and clinical symptoms. He's doing one exclusive course for PGs. And this is infectious diseases. The evening time is going on.
So exam will be conducted how?
Yeah, exam will be
MCQ
conducted there.
based.
Exams will be conducted there. So based upon the modules, we are going to conduct the examinations there. So APA and ICP is
Ah.
working on mode there. Mostly it's online mode they're planning to conduct there. So they're planning to conduct and they want to give some modules also to the students at the end of the course because half an hour it's very difficult to half an hour to 45 minutes very difficult to grasp everything. So we're preparing some modules at the end of the thing and we are planning to conduct on small certificate examinations at the end of all modules.
Mm. Okay.
No registration fee,
So
nothing.
this degree, I mean, this certificate is given by API, is it?
AP, yeah, under Indian College of Physicians, they're providing it there, ICP. The API wing of
Oh,
ICP is doing it, yeah. Under the banner of API, but ICP is only
yeah.
coordinating that. Now the ICP deal only is in charge of this one.
Sure.
So we'll start like a sharp at 7:30 there. I just check whether Tiwari sir is joining or not. If not, I can give you an interview of you. Then we'll start there.
But if I post some questions, how do you know how they're answering? Are
I'm
they
like a
going to
monitoring the
get?
chat box there. I'm checking the like a Q&A box part there. So whatever the answers they are
So
answering,
I won't be able to see what they've.
if problem is like a first couple of sessions like we didn't unmute it, we asked the participants to like discuss, but a lot of like cross voices people start open up the thing and they just discussing with the like
I know.
that's why we
Got
say
it.
like
Got
we
it.
block other people, only the speaker and the moderator, other things, that's the issue. So we put them in the chat box, like whatever the chat column, answer the things. I put like a MCQ type questions there. So I ask them to put 1, 2, 3 so I can have interactions with them there.
No. I am planning to ask some questions.
I
So
know.
when they answer, you're
They
going
can
to
ask him
coordinate.
to type
Is
it
that
out
it?
there so that I can read out there. Otherwise, a couple of participants we can ask them because they
But
can.
I won't be able to see them, right?
I can read you for you
When they type out.
uh, I
Okay.
I
Got
can
it.
read out for you there.
Yeah,
You can
understood.
focus on the presentations. I can read out the questions and whatever clarifications they ask. Then in there itself, I can put it to you there.
Yeah. Because case-based I've
If
done.
really needed, I
So
ask couple of
there is
participants to
some
unmute
chat
also there.
box
Yeah.
typing is going on here. Yeah.
Yeah. So couple of participants we can try to unmute today and check whether today some like a discipline is followed or not. We'll just check.
Fine. No.
It's possible there. I think admin side, like somebody join, no, suppose somebody want to raise a hand so that you can unmute the participants and ask them to do it there. Ask some questions or answer some questions. Admin side, anybody is joined, no? Anand? Anand is joined?
Yes, sir. Good evening.
Suppose
Good
you
evening.
we'll put in like ask him to raise a hand or hand symbol. So those who
Okay.
want to answer the thing on interactive thing, you just unmute them there. Others you can mute.
Okay,
What are the
sure, sir.
persons who want to like answer or participate, just unmute the participants so that you can have discussions with the faculty there.
Okay, sir.
Okay. Okay. So another 1 minute to go. I just. Yeah. Anand, Dr. Tiwari sir has joined?
No, sir.
Okay. I just check. Okay. Yeah. Still not fine. 30 participants, 28 is fine. Okay. Good evening, one and all. It's great pleasure for me to moderate the sessions on UTI diagnosis and management. Today's faculty is Dr. Muralidhar Verma, is a well-known persons and in the field of infectious diseases and is professor and head at KMC Manipal, Bangalore. So he has got a lot of publications and is chairperson of the Infections Control Committee also, one of the sought-out speaker. And today is going to discuss UTI. Basically, he's focusing on simple case-based approach is we're going to follow today. I ask the participants, those who are really interested to interact, please not those who are really interested. I think everyone should interact with him because he's showing a couple of cases there. So you can take turn and you can interact with the faculty. This is a slightly changed sessions. We usually ask them to put it in their questions and doubts in the chat bot. But today, if you want to interact with the faculty, we just raise your finger, raise your hand symbol so that the organizers can unmute yourself. You unmute so that you can interact with the faculty today. So please use this facility and interact with the faculty. Whatever doubts or whatever discussions you want to do, please do it instead of a monologue. Make it as a good dialogue today there. So he's willing to provide a couple of cases and practical cases he's going to put. And this is all simple and practical for a postgraduate level and what we need to do when we encounter UTI. And towards the end of his presentations, we can keep some Q&A also. Apart from the in-between Q&A, we'll keep some Q&A time. And finally, we'll put some of the post-test questions. As usual, we can put some of the post-test questions to check how much you grasp this one. So this is a wonderful opportunity. I again sincerely thank the AP and ICP for giving this opportunity to moderate, and also thank Dr. Muralidhar Verma because on short notice I agreed to do this talk without any thing. So I sincerely thank Dr. Muralidhar Verma, and I ask the participants also for joining on time and keep the WhatsApp, what we call, keep the Zoom webinar ethics clear there. So don't switch on your phone when others are interacting. Please keep this silent mode and allow the participants to interact. So without further ado, I ask Dr. Muralidhar to start his presentations. So stage is yours.
Yeah, thank you, Dr. Suresh. Thank you for the opportunity. As you said, I will show cases which I have managed, and through the cases I will show you how to manage it. These are the cases which I encounter on regular basis. Dr. Suresh, can you see my slides?
I am seeing slides, but it's not in the slide show mode. Can you put it in the show mode?
Is it in slow mo now?
Yes, now, yeah, correct. Slide show is there. Yeah, correct.
Okay. Yeah. Good evening. As I said, so what I will do is I'll build up a case. We'll try to make a diagnosis, and then we will learn few points and move on to the next case. I'm supposed to talk for 40 minutes. I thought I was for 1 hour, but probably some of them I will skip. But Suresh, you can just tell me when it is getting some time getting up.
Sure.
I might take a little bit longer, but I can skip the last part.
Sure, no problem.
Okay, fine. So I'll start with the first case. This was the lady about a year back I've seen. It's a simple case which we routinely see. An unmarried 23-year-old female presented with burning micturition for 3 days. No history of fever. She doesn't have any premorbid illness. Vitals were stable. There was no suprapubic pain or renal angle tenderness. So what is her diagnosis? Is it cystitis? Is it pyelonephritis? Is it vaginitis? Or cellulitis of the perineum? Somebody wants to answer this?
Those who want to answer, please put your hands up and answer. Otherwise, some of the people who want to chat.
Okay, yeah, no, I can see it.
Okay, sure.
I think you can type out. Some people are writing cystitis and all. Somebody has written 1 and 2.
Sure.
Yeah. Why you all choose cystitis? And what is the meaning of cystitis? What do you understand by the term cystitis? Somebody wants to type it out?
Any takers can
Everybody
pick up the mic
agreed.
and also. Any takers on the mic?
It's a bladder infection. Okay. Fine. Yeah. Somebody has, Mahesh has said it is inflammation of the bladder. And why not it is pyelonephritis or vaginitis? No fever. Okay. Fair enough. Fair enough. No renal angle tenderness. Yeah. So at the same time, you should be aware that some of these signs are not very sensitive, but if it is there, it is great. They're very specific. So why can't it be a non-infectious condition which is mimicking like a cystitis? No vaginal discharge, obviously I have not told. So, and very important in this is many times even me, because females we don't examine, it could be a cellulitis and people say I have pain there and we assume it is pyelonephritis or cystitis. The lesson learned is until you examine that area, you can 100% never rule out cellulitis of the local area. I myself have missed some cases like that unless OBG people picked up and told it is not UTI. So it's very important you do a thorough examination. So we'll move on. Yeah. So it's important that you make a clinical diagnosis is more important than your labs. So that is very, very important. So first take a good history, examine the patient, come to a clinical diagnosis, then go to the lab. Because nowadays, most of our PGs look at the lab and say, this is what my diagnosis. I think still traditional way of looking history examination, then going to labs, still it is important. As we go on to the other cases, you'll realize how that is important. So question is, how do you differentiate lower and upper UTI? And then we'll go and discuss what is upper and lower UTI. Somebody want to attempt this question. How do you differentiate lower and upper UTI? Can start typing out in your chats. Lower and upper UTI. Fever. Okay. Fever is suggestive of, I believe it is for upper. Renal angle tenderness. What else? Yeah, correct. In the previous case, these were not there. What else? What else will suggest? Okay. So it's important to understand. First, we need to know what are the syndromes of UTI. Okay. This is a traditional way of teaching asymptomatic bacteria, which we will discuss. There is something called upper UTI and lower UTI. Upper UTI is pyelonephritis. Again, there are a lot of varieties. Lower UTI, which is cystitis and urethritis. And there is something called febrile cystitis. Like somebody said, okay, fever is there, that is why it is no fever, that is why it is cystitis. But there are conditions where patient actually has cystitis, can have fever. It need not be always pyelonephritis. And the last one is catheter associated UTI. If we have time, we will discuss that one also. So what has happened now is, which is, I think makes a lot of sense, is this whole classification has been revised now. I think this slide sort of encompasses all that. I think that clear anatomical distinction that, okay, it is cystitis, that is why it is not a systemic illness, is no longer accepted now, or no longer thought of. It's no clear red line saying that this has to be localized. Ultimately, what we forgot in that classification is who is your host. If somebody has a lot of risk factors, like I have put up in this slide, a lot of risk factors, then even a cystitis can go on to become sepsis. The risk is lower, but it still go on. Traditional teaching is, okay, cystitis means you cannot have sepsis, but it can still have, right? So this thinking that, okay, by differentiating cystitis and pyelonephritis, my treatment management will completely change, you might be partly right. So always look at who is your host, right? Is the patient having uncontrolled diabetes? Is the patient having any foreign body? A lot of things. Is the patient pregnant, etc., etc. So that, please be careful. These are all very dynamic definitions. At a given time, they can switch over. Okay, I hope you understood the new classification of this. Now, what are the features which have been traditionally told to have for upper UTI? Certain things are definite, but sensitivity of some of the signs are not very high. Like fever, I told you, fever is there. Yeah, it is pyelonephritis. But as I said, there could be febrile cystitis also. Similarly, pang pain, costovertebral angle tenderness also are features of pyelonephritis, but they're not very sensitive. Very few people have. But if it is there, great, definitely it is. When you have hypotension, patient says I have no fever, a burning micturition, BP is low, it has to be pyelonephritis. And altered mental status, especially when elderly people can present with altered sensorium, it's about 20-30%. But nowadays, people are overusing that, and every altered sensorium thinking it's UTI is also wrong, especially in hospital. It could be meningitis, which might be completely missed out. So again, good history taking is very important. Labs look presence of high counts, high CRP or bacteremia definitely suggests it is upper UTI. So these are some of the important things. Again, as I said, it is no one thing should not say, okay, this has to be pyelonephritis, this has to be cystitis. It's a combination of host, symptoms and labs. So what are the investigations we do for UTI? One is counts, urine routine, urine culture, blood culture, ultrasound abdomen or CT scan, right? So can somebody answer how a urine routine will help us make help in make a diagnosis of UTI? And any of the PG want to answer that? Just looking at urine routine, can we guess, okay, this is UTI? What are the issues? Can type it out. Just looking at urine, can we make a prediction that, okay, this has to be UTI, or there are the challenges in looking at urine routine? Bacteria, pus cells, a lot of people have written as pus cells. Yeah, nitrates positive, color. Yeah. What else? So Are there any other conditions where you have pus cells and actually it is not UTI? Is it possible that you can overdiagnose it? Okay. So let us look at the same case which I have told. This is that young lady's culture. If you can clearly see, there are nitrates 2 plus, leukocytes 3 plus, and there are numerous WBCs. So is this suggestive of UTI? Which of these parameters are best? Urine leukocyte, urine nitrate, or WBC? Which one you think is the best way to make a diagnosis of UTI? Or we have to do culture in all? Nitrates, okay, right? Okay, fair enough. Teja, WBC. So there is a difference in opinion. So as we say, no single thing is ever useful. Again, in the context becomes very useful, right? So we'll look into that part also. So leukocytes, if you look, it's basically a marker of WBC. It's positive in most UTI. Like look at it in a negative sense. If there are no WBCs patient not on treatment, then very unlikely this patient has UTI. So look for UTI mimics like vaginitis, etc. Nitrates, basically the problem with nitrates, it is great, but it will be useful only if certain bacteria will not, like enterococcus, it might miss. So high specificity for UTI. But pus cells, this is a traditional definition. I'm not a great fan of this 5, but I'll show you one study how they've analyzed it. Bacteria presence are very, very useful, right? In our lab, they reported. But ultimately, you need to look at a combination. Okay, pyuria and bacteria. Why is this useful? Because urine routine can come in a couple of hours for you to make a judgment like whether it's really UTI or not. And to a certain extent, probably the response also. But again, look at in the context of the patient always. So urine leukocyte esterase with nitrate probably has a highest predictive value, right? Remember that most of our patients would have taken antibiotics, so some of these are not really useful, but in the context, you should always see. So this is one very interesting article which was recently published, okay, where they looked at by just looking at urine leukocytes, can we predict whether it's asymptomatic bacteria or whether a patient can have complicated UTI? In the sense that complicated UTI means can they have UTI like with blood culture, bacteremia like that. So what they found is they've given a cutoff, right? 490 versus 125. So 125 is for asymptomatic versus somebody who has UTI. So you can clearly see 5 is a very low limit. So you have to look at it in the context of the patient. This is a very interesting study which it has a practical value. So if somebody says I have very high urinary leukocytes, say 500, 600, probably it is very likely the patient has UTI and probably have an bacteremia also. I have not shown you the entire study. People can read about it. So you always look at it. Some of the small tests which doesn't cost too much can really help you. Urine culture. How many of you want to send a urine culture for this patient? How many of you want to send? Yeah? Yes? Some people are saying yes, some of them are no, right? Again, I think it all depends on whether this patient has come first time to you, first episode. Where are you practicing? Say in university hospital like KMC Manipal, probably I will send because most patients would have taken treatment somewhere or something like that. Okay. Otherwise, first episode, young lady coming to UTI, I think I can get away without urine culture. I can empirically treat because very unlikely it is complicated. Very unlikely the patient can have drug resistant UTI. But nowadays, the community acquired infections are becoming more and more drug resistant. So nowadays, we would prefer having, but traditional teaching is may not be required. But you can always ask. Very important to ask, how do you send the urine culture? What instruction do you give to the patient? What instructions do you give when they send for urine culture? Okay, everybody is answering. So we always tell clean the genitalia, yeah. Midstream clean. There are two words in this. There's midstream, that means, and clean. First clean the area, make sure you give a sterile container, and then ask the patient to pass urine little and then give the urine sample. So that's important. The logic is the first urine might be contaminated by the outside vaginal cells and bacteria, which can give a falsely positive report. Okay, so these instructions are important. Many times these small things are not addressed in a busy OPD. It's important you instruct the patient. So management, you want to start empirical antibiotic, and what do you want to start? Will you start ciprofloxacin, or will you wait for urine culture, or you give symptomatic treatment, come back, or say, okay, we'll start injection ceftriaxone? Which of these four will you choose? Nitrofurantoin. I have not given you that choice. You're fine. Wait for urine culture. Fair enough. Start ciprofloxacin. Cipro. Okay. I have not given you some more options. You can always choose. Right? You can always choose. So again, this is the debate. Always have. Shall we just do a treatment without fosfomycin is overkill? Right? Definitely not fosfomycin. So see, I think you need to understand, being very scientific and being practical, sometimes cotrimoxazole is the right answer, somebody has said. You have to balance out who is your patient, how much she is suffering or he is suffering is very important, right? If you want to go by science, okay, patient is not much symptoms, you give symptomatic treatment, come back to our culture. Patient may not come back, right? Nowadays, nobody has patience, right? So in that context, starting an empirical therapy is no problem. Even without urine culture, you can start. All you need to have a knowledge about certain history, like what are the drugs which have a good urine concentration. Second, are there any contraindications? Always ask. This is one thing many times I find our PGs or a lot of consultants keep forgetting. Patient might have had a seizure and you're giving ciprofloxacin. So it's important to understand that. IV is definitely an overkill, definitely not required. So we'll move on. So how do we choose empirical therapy? There are different ways of choose. You can use standard guidelines, but some of them are not from India. Or you can have your own antibiogram of your hospital, like in university hospital or a corporate hospital you'll have, you can choose it. I'm just put one, it's not related to, this is our protocol. It can change depending upon it. But generally, uncomplicated young lady coming to OPD, remember this lady is not in the ICU or in the hospital. So we need not give IV drugs. We can give oral drugs, and you should be aware of which are the drugs which have a good urine penetration. One, quinolones. Any other drugs which have a good urine penetration, like good concentration in the urine? Can you name the other antibiotics? Other antibiotics? Somebody is answering. Cotrimoxazole, yeah, cotrimoxazole, nitrofurantoin, excellent. Try avoiding cephalosporins. They're found to have a bad outcome, and we are hardly using nowadays, right? So it has less efficacy and high risk of resistance. So don't use, because there are various combinations available in the market. Cefixime with something else, cefpodoxime with something else. So all these are inferior, even though they're sensitive in the culture report. So try avoiding those drugs. Cotrimoxazole, quinolones, nitrofurantoin are all fine. So this is how urine culture has come, but unfortunately they have written as colony count as 50,000. So what to do now? Do we need to take this urine culture seriously or not? There's a patient I told you many months back I've seen. So what to do now? Colony count is 50,000. Is it significant or not? It is not significant. Fair enough. Fair enough. It is definitely not significant. Agreed. So all of you are agreeing it is not significant. Yeah. So this is where understanding the science becomes very important. So first thing is you should know how this colony count is done and how much errors can occur. Okay. Second thing is this colony count business is not for symptomatic patients. So I won't even look at this colony count in this patient because this patient is symptomatic. So I'm not interested in this, right? So second thing is, how many of you know how the colony count is done in the lab, right? I mean, because of lack of time, I can't sit and explain that. But what I'm trying to tell you is there are a lot of errors. There's a lot of individual variation which can occur, how your technician is trained, how fast they've done. I mean, there are a lot of things which can. So again, goes back to the simple rule that 10 to the power of 5 is taught so much that we think only that is a gospel truth. It is not, right? In a patient who is symptomatic, any colony count is important. Okay, so I will respect this report. Agree? So that is a lesson learned. So I didn't even look at it. I highlighted so that your eyes will go there. That is only logic. So now patient is getting better. Now culture report has come. What will you do? Initially you started ciprofloxacin. Will you change it to injection amikacin, piperacillin tazobactam, ignore the report, or TMP SMX, that is cotrimoxazole? Which one will you give after the report? I'll just go back to the culture report for those who have missed it. Ignore the report. Okay. 4. Okay. D. Okay. I'll just go back. So I just wanted to see. We can't completely ignore the report. I told you patient is symptomatic, but definitely I will treat this. But what you need to understand is, see, this culture report, what is done in the lab. Co-amoxiclav, somebody wants to try, fair enough. It's intermediate sensitive. I'm not going to sit and teach you what is MIC and all. There is one simple lesson you need to understand. So this patient have started on actually cotrimoxazole. This report came after 3 days and it is resistant. But patient says she is better, she is improved. The reason we need to understand, remember she is cystitis, first time UTI. Unfortunately, she is already having an ESBL strain of E. coli. So what you need to understand, if the patient is responding, you need not bother too much. Why? Because the drug what I choose has a very high concentration in the urine. Very high, hundreds of times higher concentration than anything. In the lab, what they do is they give a fixed inoculum. At that concentration, this might be resistant, right? So if the lab says it is resistant, it is not all or none phenomena. It only tells you the probability that this may not work in the context, right? It's only probability game. You're saying it is high likely patient can fail, high likely patient can have recurrence. But in the context patient is responding, I would rather wait rather than, because other options are all IV. Okay, so that importance you should know how they test in the lab, what are the limitations versus the drug pharmacokinetics. Okay, so I just continued cotrimoxazole. So now question is, clinical correlation of culture report becomes very, very important. Not that I'm saying that I will completely ignore. If the patient continues to have fever or comes back with fever, probably I'll start respecting it and offer them IV medication. So then there's one more culture which has come. Okay, same patient, I've just wanted to tell you. In this patient, what will you do? You'll continue cotrimoxazole because this patient is showing sensitive, right? I could have not chosen Norflox, I would have changed to oral cotrimoxazole. Just want to tell you the context. This is not the same patient. This is a different patient. Okay, here colony count is significant. If I would have started ciprofloxacin, I would have switched over to cotrimoxazole because my chance of patient improving is very high. I will not choose oral cephalosporins. Please avoid them in UTI. Okay, now how many days do we need to give? Can somebody tell how many days you want to give? UTI? 5 days, 5 days, 5 days. Yeah, 5 to 7 days is fair enough. Remember, she doesn't have any major issues. Fair enough answer. So what we're trying to tell is, this is a very nice publication. One of my favorite authors, Brad Spielberg, is one of the co-author. You can read this article, how the world is changing from a shorter regimens. You need not always have a longer regimen. So Messi, when he was born, said he will never succeed. You can see that shorter is always better, right? Even though it's not tall, is one of the greatest footballers of ever, right? So it's always that. Now, next case, I'll move on. I'll move a little bit faster because of short of time. So here is the lady who is 56-year-old female, diabetic, admitted about a month back under us, fever, burning micturition 6 days, low backache, she said. Initially, she went to orthopedics because they said low backache, right? When she came, her BP was low, pulse rate, temperature was high, and there was a law and tenderness. What is the diagnosis and what empirical diagnosis? This is a straightforward one, right? Can somebody tell what is the diagnosis? You want to answer quick. Pyelonephritis, correct. Somebody has put a question mark, please don't put. It's definitely pyelonephritis, no doubt about this. Okay, so what drug will you start for this patient? What empirical antibiotics will you start? Piperacillin tazobactam, fair enough. Piptazo, yeah. Don't use commercial names. Magnex, somebody has written ceftriaxone sulbactam. Most people have chosen Piptazo. Fair enough. Again, I'm telling you, it might not be correct because meropenem, okay, we'll discuss about it. So it depends on what is your local antibiogram, but all answers are fairly correct. Previous cultures are there, we can use fairly good enough. It all depends on how fast can you act. Somebody said levofloxacin. No, levofloxacin is the wrong answer. It's too much of a risk. Probably 20 years back, you are right, not now. Too much of drug resistance now, right? So what are the labs you're going to ask in this patient? Will you ask blood culture? Yes, ultrasound and CTKUB. So these are the counts. As expected, counts were high, platelets are fine. Creatinine is 2 point. Somebody has written additional of nitrofurantoin. No, wrong answer. I don't think so. We should add nitrofurantoin. Glyco-HB is 9. Okay. A1C is very high. So definitely this patient has a complicated UTI, pyelonephritis with a shock. So what else will you do apart from antibiotics? So remember the simple rule in sepsis. This patient is in sepsis. Absolutely no doubt in that. There are only 3 pillars of sepsis. One is source control, right? Second one is correction of abnormal physiology. The renal failure give hydration, hypotension give inotropes and fluid, LFT you give whatever. You can give anti-hepatic encephalopathy measures, fever is there. So correction of all abnormal. Somebody has hypoxia, give oxygen, right? All this. Last one is antimicrobial. So these are very important. Source control, right? Very, very important. Relieve the obstruction, absolutely correct, right? So you do imaging, relieve the obstruction, drain the abscess. I just hope this video runs. I don't think so it is running. It's a very, very important. Can you see this video, Suresh?
No, Dr. Muralidhar. No.
Can you see?
No, it's not running.
Oh, okay. This is a very nice video. Okay. Let me see. I'll take 1 minute on sharing this. Can you see now?
Yes. Yes, we are
Yeah,
seeing.
see, 2 people, the ID people, medicine people are struggling to kill the bacteria. All the surgeon came and allowed us inside. Simple video, but makes a lot of sense. That is what source control is about. I'll just run it. It's only few seconds. See how I'm banging the door with all possible antibiotics. Nothing I can do. Surgeon comes, cool, takes away all the source. Now the bacteria is dead. Okay. So that is the beauty of source control. So always remember source control is probably more important for me than giving antibiotics, because antibiotics cannot reach inside the pus or obstruction. So one more thing I keep seeing in the lab reports is KUB, especially is fat stranding. Fat stranding is a fairly okay sensitive report. Fat stranding is basically whatever fat is around the kidney. If the kidney is inflamed, it can cause stranding, extra stranding. You can see this is uninfected kidney, this is an infected kidney. You can see that fat clearly standing out prominently. That's what fat stranding. But many times radiologists sometimes overdiagnose, don't go by, okay, radiologist has written fat stranding, now it is UTI. Again, it goes back to good history examination. Am my patient likely to have your urine routine, your cultures, etc. So, but I keep standing, that's why I thought I will touch upon this. So, patient started which empirical antibiotic? We have answered this. Why can't we choose only amikacin? Somebody wants to give only amikacin? Is it okay to give only amikacin? Dr. Suresh, can you see my slides?
Yeah, Dr. Murali, I'm seeing your slides there. Management part you're putting.
Yeah, okay. Somebody has reported as renal failure. Yeah. Other thing is, you're right. When there is a renal failure, even the amikacin has a great nephrotoxicity is not my real concern because, yeah, absolutely. There are two reasons why. One, once there is a renal failure, the renal penetration of aminoglycoside significantly comes down. Second thing is, here patient has hypotension. That means the blood is also likely to have bacteria. For bacteremia, non-beta-lactam drugs are not great. Okay, you can add on, but never give because they never reach good concentration in the, remember. So the rule of thumb is if somebody has bacteremia, the drugs of choice are always a drug which contains beta-lactam ring. That you should remember. Why not teicoplanin? It's a overkill. We are not suspecting gram-positive coca here, unlike skin and soft tissue. I believe that last class was on that. So we are not suspecting, so you need not cover teicoplanin. Now, next, there is some trial called as very famous, people keep quoting. I thought I'll just cover it as Marino trial. Okay, basically it was published in 2018 in JAMA. What they've done is they looked at all the bacteremias caused by ESBL strains, and one arm they gave piptaz, other arm meropenem. So the piptaz group did badly compared to meropenem. That's why they say compared to beta-lactamases, meropenem is better off. But again, there are a lot of issues with this study. Remember that once you have a culture report, probably you are fair enough to do any of those drugs. Okay, until the culture is available, probably you can use meropenem. That is fair enough. Okay, but you need to step down. So before we go on for this patient, there are a couple of things I want to tell you. There are different types of pyelonephritis. One way of classifying is acute and chronic. Other one is renal abscess. I'll show you some of our patients' images. Renal abscess. Other one is emphysematous pyelonephritis, very classically occurring in diabetic patients. Last one is xanthogranulomatous pyelonephritis, typically associated with staghorn calculi due to chronic obstruction. I'll show some of them. This is the patient right now we have in our ward. So you can see the bulky kidney. Sorry, I took the image in the last moment. This is the bulky kidney. This is an abscess which is forming. So once it forms, they need to drain it. That's the importance of it. Of course, we already put a stent here. Okay, renal abscess. Second one is emphysematous pyelonephritis. Very classic, typically occurs in diabetic patient. You can see the gas forming E. coli. They're E. coli, but they form gas. You can nicely see that you get the pus coming out of the urine bag. Very classic. Mortality used to be very high. Nowadays, we are picking up early and doing the stenting, sometimes nephrectomy like that. This patient underwent nephrectomy because it was very bad. Then there is something called as xanthogranulomatous pyelonephritis. It is a chronic infection forming granulomas. It is supposed to be classic bear paw appearance. Okay. I will not be able to discuss much because of the want of time, but you should be aware this treatment is different. Okay. Typically associated with staghorn calculi because of chronic obstruction that happens. There are a lot of treatment options, right? So these are some of the things you should be aware of. Then the cultures have come, both are growing E. coli. Again, you see this is only 10,000, but has no meaning for me because blood is already growing. So now I have a lot of options. I can continue to give carbapenems, or I can give piptazo or ceftriaxone sulbactam, but source control becomes important. Okay. I want to show this slide. When somebody comes with uncontrolled diabetic, if something is not growing, talk to your lab. This could be bilhardosis. Okay, blood can grow. Many centers don't have, but we have one of the best centers to diagnose bilhardosis. Dr. Chiranjan is a pioneer in that. So we have been doing this work for a long time. So always remember, uncontrolled diabetic, if you have a patient who has pyelonephritis and bacteremia, please think of bilhardosis. Bilhardosis can have soft tissue infection, lung, brain, anywhere, right? So just remember, diabetic patients in postgraduate exam, they will ask you, what are the common infections you see? One, start from the above. You are very prone for mucormycosis, what we call black fungus, right? Second one in the lungs, of course, tuberculosis. Then in the kidney, it is emphysematous pyelonephritis. In the abdomen, again, is emphysematous cholecystitis. And the last one is bilhardosis. Don't forget, it will mimic tuberculosis and other bacteria. These are the 5 things commonly asked during your exam. So whether to change antibiotic, yes, it's better to de-escalate because this is what is called antimicrobial stewardship program, source control based on clinical condition. If you have drained the pus, patient is getting better, you can definitely step it down to prevent resistance. So nowadays, what is happening is we are seeing a lot of carbapenem resistance. I thought I'll put a slide on it. This is how one of our patients we have recently everything is resistant, only fosfomycin. So there are very few options for them. I just put up what are available. Ceftazidime-avibactam may or may not work. Lab should do the test and tell us. Fosfomycin is great, comes with a lot of issues. It can cause a lot of sodium load, fluid overload. Colistin, remember polymyxin B will not work because it does not penetrate kidney. It has to be colistin, so it increases the risk of renal toxicity. Aminoglycosides, if they're sensitive, meropenem or oborobactam, it's not available in India. Ceftriaxone not yet available in India. So there, of course, there are a lot of options I just put up. So these are some of the options. So lesson learned is if you have E. coli in the urine, you can't use polymyxin B. You have to use colistin, that is polymyxin E. So how long do you give the duration? So somebody wants to answer, is it for 1 week, 10 days, 2 weeks or 3 weeks? How do you decide? How long to use? 2 weeks? 2 weeks? Okay, many people seem to agree. Yeah, that is a traditional teaching. Correct answer, 2 weeks for pyelonephritis, definitely. Question is, can we switch out to oral? There's no great data right now. At the same time, there is emerging data saying that we can give shorter. Again, it boils down to good principles of medicine, that have we controlled the source? Abscess has been drained, stent has been put up. Is the systemic diseases like sugars, steroids have been stopped, other immunosuppressions have been stopped? They are as important. If they're not done, I have a patients where I have given it for 3 or 4 weeks also. Always look at an individual patient, but I think 2 weeks is fairly good answer, 10 to 14 days. So next case, this is one case of female primigravida. Last week I have seen. On routine testing gynecologists, they found the WBC was 30 to 35. What do you want to do now? They refer to us what to do. Shall we treat or not? What should I do now and what is to be done? Treat it. Okay. All of you agree with treating it? Why need to treat? She has absolutely no symptoms. Just now I've been telling that somebody said treat it. Depends on her symptoms. Treat it as it is, primigravida. Okay. Right. So there are certain situations where we might have to investigate. So treat it may not be correct answer. Probably what I will do is I will ask for a culture because there's no emergency. So based on the culture report, I can decide. So this is her culture report. Okay. You can see that it is again a ESBL strain. There are many oral options are there. One is cotrimoxazole, unfortunately Norflox, gentamicin and all are there. So what will you do? Will you treat it? Yes, we need to treat, definitely. This is one condition where asymptomatic bacteria have to be treated. Like usually what in gynecology we do, we tell them is screen between 12 to 16 weeks. Again, it is individual guidelines. Why asymptomatic pregnant women should be treated? It reduces the risk of pyelonephritis. Remember that as the pregnancy advances, starts compressing onto the lower UTI can cause transient obstruction. If already infection is there, that can flare up. And there's also risk of preterm birth, low birth weight, etc., and reduces maternal mortality. Now, question is, what drugs can you give in that patient? I'll show back the UTI. What drug will you choose in her? Which of the drugs will you choose? Which drug will you choose? Coamoxiclav. Okay. Others? Septran, coamoxiclav, cotrimoxazole. Fair enough. No IV. Okay, coamoxiclav. Yeah, many people seem to be piptazo. Yeah, see, all answers are right in the context. Remember, this lady is asymptomatic, primigravida coming here. Definitely, I will choose oral. But here there is a catch in oral. I need to look at which are the drugs which are contraindicated in pregnancy, in which trimester. Okay, so before we go on, these are some of the conditions where asymptomatic bacteria has to be treated. One is pregnancy, irrespective of trimester, urological procedure, expected mucosal bleed, kidney stone with manipulation, recent kidney transplant. Again, recent kidney transplant, there are some issues about guidelines, but I'll just stick to the standard teaching. Okay. So now we need to understand which are safe in pregnancy, which are not. Tetracyclines, cotrimoxazole, somebody has written, probably I will not give it. Comoxiclav probably was the right answer. Fair enough. Nitrofurantoin also was not a bad choice. I just gave comoxiclav, even though traditional stopped using it. The UTIs, the outcomes were a little bit poor. Again, you need to decide. If the patient has some other gynecological issue, I would have offered IV drugs also. Okay, fine. So apart from knowing sensitivity, you also know contraindications also. That's what this tells, and which are the asymptomatic conditions where we need to treat. So I'll just jump to next case, then we'll ask Suresh whether how long can I continue. So here is one case. This patient was referred to us. This is about a couple of months back. Patient is kept on having UTI, and they called us and said, Dr. Verma, there is an issue. We want to prevent. So patient was sent to OPD, and how do we manage? So how do we manage this case? Can we give antibiotic prophylaxis? So they wanted to give how to choose. This patient has CKD, not on dialysis. Creatinine was 6 or 7, GFR around 20. Yeah, you want to give prophylaxis. Okay, fine. Right. Everybody is agreeing for prophylaxis. Okay, so again, don't forget medicine principles. Most important question in medicine is why. Question is, why is this patient having recurrent UTI? I think that is more important. What did they miss and what way an ID person can give a better? All I did is I want a better imaging, right? They have done an ultrasound, non-contrast CT. I said, please do a contrast CT. It's okay. Patient is anyhow planning to get dialyzed now. All we did is that when they did ultrasound and all, we can clearly make out that it is irregular. It is not uniformly thickening. That tells you that this may not be straightforward bacterial UTI. Okay. So because of the abnormal bladder, there is a recurrent UTI which is coming. So ultimately, images had some issues I could not think. I told do a cystoscopy and do a biopsy. Biopsy showed granuloma, and gene expert was actually, this is a case of TB bladder. Because of the abnormal bladder shape, patient is having recurrent UTI. So the principle learned is, just because something is growing, don't look at only that. Okay, you need to understand why it is happening. Is it because of anatomical problem, or is it some alternative diagnosis? Same things haunt us every day, in fact. So don't forget what your professors are teaching you, how to manage a complicated case. Common things are still common. Rarer things are still rarer. Okay. This case I will show, then probably I'll tell if Dr. Suresh has time. So this is the lady right now I'm treating since 1 month. So she comes to OPD. She's type 1 diabetic since the age of 8 years. She is, she should be really brave that every day she checks her sugars. I mean, she's a really motivated girl. So what happened is she went to Canada for some college. She came back. Comes back with UTI. So I have not involved at that. So local hospitals were treating 3 episodes of UTI. All of them were ESBL E. coli. One of them required hospital admission, not under us. So somewhere else. Then finally fever is not coming down. Somebody said, okay, go and see Dr. Verma. Okay, sorry, last minute typing. I think there are some spelling mistakes. Referred for fever and chills. It is not chills. Okay, I don't know what is the meaning of that. I'm sorry about it. Right. So that is what I've seen. Right. Now, on examination, vitals are stable. She says nothing. She's an educated lady. She understands whatever I'm trying to tell. Right? That's good news. So then I've asked for basic labs. You can see the counts are very high. Right? You can see the counts are very high. Urine is showing numerous pus cells, nitrates positive, leukocytes. So definitely this is UTI. So we can 100% say that this UTI is a true UTI. It is not a mimic. Right? An examination. So labs, RFT was normal, outside CT scan normal, so I didn't repeat it. Can it be fungal culture? Okay, fair enough. We have sent a culture, I'll show you. That is not the point. Fungal culture. So we have sent cultures. Of course, I have asked my sonologist to do an ultrasound. Like the previous case, I don't want to miss one TB or something like that, but bladder, everything is normal. There's no abnormal bladder, unlike the previous case. So fungal UTI is very rare, and most important, if somebody reports candida in the urine, don't treat it unless it is really fits into your whole picture. It's extremely rare to have candida cystitis, very, very rare. Only in certain conditions you get. So be careful when lab reports candida in the urine. Okay, this is our urine culture. You can see again it's ESBL, but there are cotramoxol sensitive, Norflox is resistant, Pomoxiclav is sensitive, but MIC is a little bit on the higher side. That is what she has. So now what do you want to do? So I want to give injection ceftazidime sulbactam for 14 days, follow up the patient and what to do about it. How many of you agree with my choice? This is my plan, okay? This is my plan. Do you agree with my plan? How many of you agree with my plan? Yes, we can try OPAT, okay. You want to try cotramoxol, right? But remember, this patient is having fever and chills. Okay, this patient has fever and chills. Somebody has said yes. So again, it goes back to the principle. What has happened is, fortunately, I took a good history and she's, I asked for, did you ever have allergy anytime? Yeah. I had some allergy to one drug. So obviously, sulfur drugs will come to my top. It could be penicillin allergy also. Father fortunately remembered and showed me one small slip. Yeah, she has sulfur allergy. So obviously, cotramoxol is out. Even then, when somebody has fever, probably giving cotramoxol was not a great choice because fever means bacteremia. Your blood culture was sterile. But what happened is she says, I just don't want IV drugs. I said, I will neither because I'm very difficult to get a vein in her because of various technical reasons and she has some skin related issues. So what we have done is, this is not traditional teaching again. Again, I think somebody is a great fan of nitrofurantoin. Yeah, I have a culture in my hand, so I'm not going to treat that with nitrofurantoin. So IV drugs is what ideal, but sometimes we have challenges. Giving an oral drug in somebody has a febrile cystitis is not a bad choice. I don't need fosfomycin because there are many other drugs I have. I am need not do that. Okay, fosfomycin in general in UTI is not well studied and outcomes are not great. I had very bad experiences with it. I will not use it until I'm desperate. So you can try comoxiclav in a higher doses, right? Usually we give 1 gram TID or something like that, but ideally we should give that. So patient followed up, she did okay, right? And she is okay. Now question is, how do I prevent her next UTI? That's the next question she asked me. Okay, so I need to be prepared for it. I've repeated a urine culture just to be sure, may or may not be required. That has come sterile counts. I have not put up with the want of time. It has become 10,000. Urine routine has become normal. Now, how do I prevent her next UTI? This is not tuberculosis, okay? And no candida in this. How do I prevent her next UTI? Good glucose control, absolutely correct. So I have done that. Her glyco-HP now is 6.1. Great, good, absolutely correct. Next, what else I need to do? Stasis, post-voidal residue. We have done that analysis, nothing. You want to give prophylaxis, Dr. Yasmin? Perineal hygiene, yes, very good. Perineal hygiene means what we tell the patients is don't hold the urine. When you're traveling, especially, always pass urine. Okay, don't use washrooms which are not clean, right? Especially that water, if you use, those bugs can get infected. Keep your perineum clean. Okay, in young women, sexually active is important. She is not sexually active, right? Somebody wants Canberry fluids, plenty of fluids. Okay. So there are a lot of options. None of them are very good. Any of this process is going on. I can't tell you right now whether she's successful. I will share you one story which I've done for one lady later. So before we understand that, I'll take 5 minutes. Probably the last section I'll skip. Suresh, is that fine? Dr. Suresh?
Yeah, it's fine then. No problem.
Just I'll finish this and the last section I'll probably skip. So what is important thing is how do bacteria cause urethra? They go up. Most of the time is ascending, sometimes from the blood. So once this type 1 villi of E. coli, this is again for E. coli, they go and attach to the facet cells. Once they attach, they form a intracellular bacterial colonies. Okay, so they produce something called as hypoxia-induced factor 1, which will protect them from immunity, and they bulge out. Can you see these are bulging out? They bulge out into the urinary cavity. Once they break open, what they do is body tries to respond it by giving neutrophils. Body does good thing by knocking them off, but inadvertently what it does is it removes the facet cells, exposing the bacteria, the lower part. This lower part, it will go inside this bacteria and stay for a long reserve. And this bacteria which has come out into the bladder cavity, they can infect the other cells. So that is why recurrent UTI occurs. So this is very important to understand. So basically, it is not about killing the bacteria. We need to change the milieu. Right? This is what is a new concept, the gut vaginal bladder axis, right? I'll try to finish in a few minutes. So basically what they're trying to tell is when your gut is infected, like we keep taking antibiotics, there is a tilt of balance of diversity of bacteria, and uropathogenic, UPCA is uropathogenic E. coli, will also change. So people who have tilt in this balance are likely to have inflammation and likely to have urinary tract infection. So that concept becomes very important. So what is the definition? More than 2 UTI in 6 months or more than 3 in 1 year. Right? As somebody rightly said, control the sugars. If there is a hardware like stent, remove it, relieve the obstruction. Prophylaxis. There are 2 types of prophylaxis. One is non-pharmacological, like perimenopausal, premenopausal women, sexual behavior becomes very important. Postmenopausal, hormone and disease-related immune factors become important, especially atrophic vaginitis. So that's where estrogen helps. Many times people forget that patients were taking SGLT inhibitors and they continue it and we are treating that UTI, right? It's a common mistake. I mean, it's not intentionally done, but nobody has done the good homework, right? And certain drugs like beta-3 adenoreceptor agonists, etc., right? Non-antibiotic prevention. Fluid intake is supposed to help more than 1.5 liters. In postmenopausal vaginal estrogen therapy, what it does is it increases the vaginal pH and recolonization with lactobacilli. Okay, once lactobacilli is there, it will not allow the pathogenic bacteria to this thing. It is available as cream and pesticides. Usually I refer it to OBG and they will take care of it. Then is methamine. It's one of more than 100 years old drug. What it does is it in conversion increases lowers the pH. But the problem is you need to give a drug like vitamin C in very high dose. Previously I used to use, but I think a lot of people complained and GFR is low, they'll get GERD, etc. Right? Can be used, but it's time-tested drug. Then Canberry, hardly any benefit. Theoretically, it looks great. Most of my patients didn't do well. Basically, due to the fructose or panthoarachnosidin components of Canberry. What they do is they prevent bacterial adhesion. But what is commercially available, the strength is too low. You need to give significantly higher number of tablets. Many patients will not be able to take that many tablets. D-mannose, I have not used it, so I don't have much. Again, supposed to help in the bladder epithelial adhesion. Then probiotics, people keep using, no. But this is the general statement, but there was one article which was published from India in CID which showed that they do benefit. So I use it, but I use more of vaginal pessaries combination like that. Again, you need to talk to your patient and decide. Then prophylaxis. Sexually active people, definitely there is a post-coital prophylaxis because there are other diseases which can be there like trichomonas, chlamydia, those things. Continuous prophylaxis. Yeah, somebody wants to know what are the predictors. I'll come to that. UTI episode should be differentiated for common mimics. As I told you, many times people will have, so old people will have some overactive bladder. We think keep on giving antibiotics. So be very, very careful. And atrophic vaginitis. Now the new term is genitourinary syndrome of menopause. Okay. So prophylactic antibiotics, there are a lot have been tried. I go by individual patient. Nitrofurantoin, somebody was a great fan of nitrofurantoin. Here it is useful. Trimethoprim containing regimen, cotrimoxazole, that is what. Cephalexin I have not used. Fluoroquinolones I have used for a couple of patients. I'll share one of my experience. Lesser resistant might be expected with nitrofurantoin compared to cotrimoxazole. But remember, we can't use nitrofurantoin if GFR is less than 30. And I usually use 100. People have tried in trials 50. But nitrofurantoin comes with a lot of problems. I didn't have a patient, but I'm scared of giving long term, right? Especially when GFR is borderline. Gastrointestinal pulmonary fibrosis is a deadly complications. But it's been well reported. I didn't have any experience because I'm not given long enough, right? How long to give? Somebody asks, nobody knows. Nobody knows. There are a lot of trials because no trial can follow for many years. So what I do is, I have only practical way. Every patient I look individually, right? As somebody said, control sugars, relieve anatomical obstruction. The girl doesn't have anything right now, but I have one patient I've been following since 2 years, right? This girl, I mean, that lady has CKD. That's what somebody said. Nitrofurantoin, how long to use? I don't use long-term nitrofurantoin because I'm scared of the long-term complication. I've not given more than 3 months. So this lady had CKD borderline, kept on having E. coli, then Klebsiella multiple times. All I've done is the patient party were fed up, not my patient, nephrology patient. So then I just put her on alternate day ciprofloxacin. Yesterday she came and she's almost like 1 year, 3 months. I'm just continuing. I don't know when to stop, but they're very happy that till now she's doing well. Once I've done 3 months back culture, it's sterile. But again, may not work in some other patient. The logic is it is resistant in lab, but it will work because it has a good concentration because GFR is not that low at in that lady. So we have to individualize what to do about the type 1 diabetic. I need to talk to her about all the things. Scotaramoxel I can't give because she is sulfa allergy. So I need to figure that out now. That is the challenge. Okay. So there is one vaccine. I have one patient experience which is available, not in India. So this is one doctor's daughter. So we found out it's available in UK. Somebody went, some the relative is coming, they purchased and brought it by a urologist. It's very interesting. All you need to do is sublingually spray it. It covers E. coli, Klebsiella, Enterococcus, Proteus vulgaris. The girl is doing okay. She's 14-year-old. I think now she's 16. Last I heard 3 months back, last 1 year, 8 months, she doesn't have UTI. It's not yet available. I've recently read that FDA has approved it. It's not yet come to India. Interesting, but I'm not sure until more data is available. I will not. I have experience with only one. So that's a vaccine, interesting area, right? So other options is fecal microbiome transfer, no experience, but lot of literature, bacteriophages. So there are a lot of options. Ultimately, the lesson is you individualize patient, talk to the patient. There is no one size fit for all. You have to balance out, use your simple principles, balance out with toxicity, and also make sure patient doesn't get you in trouble. He might come and sue you or something. Okay. I will, this is a summary of all the things from one of the journal. You can have the slides if you want later. I will skip my next topic because we have run out of time. Thank you very much. I'll
Yeah,
just
thank you,
skip
Dr.
on this.
Muralidhar,
This is
for a
about
wonderful talk.
40, right? I know it is time up. So I'm skipping the topic of catheter-associated UTI, right? I'm skipping that. But anybody wants to ask questions, I'm fair enough for them.
Yeah. Thank you
Thank you
for the
very much.
wonderful talk that you touched upon from examinations point of doing the clinical peritoneal examinations, and you updated the new guidelines of complicated and uncomplicated UTI. Then you touched upon the terminologies and importance of urine routine examinations in particular, and antibiotic policy for individual hospitals, and the colony count, the investigations, and showed a good video as well as good images of the recent different pyelonephritis parts, and touched about the antibiotic stewardship and de-escalations, and finally you touched about the preventions also, including the vaccines. That is a great. So a couple of questions is coming up. You do one thing in the chat bot meantime, because we are taking some time today. Usually we finish on time. Since like we got some communications gap, so we are showing the. You stop sharing your slide so that we can put a post-test questions right now. Dr. Muralidhar, can you
Yeah,
stop
somebody is
sharing?
asking for 40. Probably I will not have
Yeah,
time
good.
to show it.
Okay.
Somebody wants about 40. I don't think so. I didn't realize that I can speak only for 40, 45 minutes. Probably I would have
No problem, sir.
condensed it.
Sure. No problem, sir. No issues, sir. Like, this is because of the lack of
Yeah.
communication, sir. No issues. So this is a post-test actually, Dr.
Yeah,
Muralidhar.
yeah, no issue, no issue.
Yeah, you can start answering the questions. What is posted in the chat board itself, Dr. Murali. Meantime, we run the post-test questions right now. Whatever questions posted
Okay.
to you, you can just answer so that we can come
Okay.
back and discuss in last couple of minutes in orally also there. So this is a 24-year-old male female, sorry, 24-year-old female with a vaginal itching and foul smell in urine. No fever, no loin pain, no back pain. Similar illness on and off, married, one child, on examinations, vaginal discharge. How many say this patient has got UTI? All the MDPGs who registered for the short certificate course, I expect to answer so that you can get you can get your attendance today, not by putting your name, you don't get answer. That's a standard thing in infectious diseases. You need to answer the post-test questions. So how many says I want to see how many people answer the thing. I just give 20 seconds before we start putting the other questions. Is this one? Okay. Okay. Yeah. So people start answering this. Sure. One second. I just type it down. Okay. So a lot of messages coming there. Maybe. A lot of maybe is coming there. That's good. So the next question. Yeah. So why the topic, Dr. Muralidhar clearly summarized, this is one of the common bread and butter for you. Infectious diseases consults not only for ID, this is for the bread and butter for any physicians. UTI is more common, and any invasions of the bacteria into the urinary tract is called UTI. The classic symptoms already discussed, so I don't want to take time, so we can have some Q&A at the end. And this is a good JAMA paper. It says when you encounter any patients, we need to ask this question whether the person has got urinary tract infections. Last week we showed that this patient has got pneumonia. Similarly, we need to ask the questions when a person presents to you whether this person has got UTI. How to say UTI? We need to have combinations of the symptoms. I clearly shown what are all the symptoms. Based upon the combinations of symptoms, the possibility of infections can go up. But what is more important, absence of symptoms. For example, the person is not having dysuria, the person is not having urgency, the person is not having any hematuria, the chances of UTI is less likely. So it has got very good negative predictive value. But what is the recent update? We use one scoring system called bladder score. I'll show in a minute. So this is called the bladder score. What is bladder score? B stands for blood in the urine. L stands for loss of incontinence, loss of urinary control. A stands for abdominal pain. Since there are two D in the bladder, D stands for dysuria that carry 2 points. Elevated temperature, fever, repeated urinations called frequency. We need to put a score of 7. Out of 7, if the score is more than 4, the chances of UTI very high. The chances is 0, 1, 2, 3, the UTI is less likely. So we need to use some scoring system, and this scoring system is well validated. So whenever my resident goes to see the patients, they need to write a bladder score. They need to write the bladder score. What is the bladder score? But this score in OP settings, when a patient is not in catheter, this is going to be useful. Otherwise, it's not going to be useful there. When a person put a catheter, the catheter per se can cause some irritations. So this is the second case. I need to solve this case on Monday. 62-year-old male posted for TKR. Now the urine culture is growing 1 lakh colony. Patients awaiting TKR, but colony count of 1 lakh. How many people want to treat? Dr. Muralidhar clearly told this is asymptomatic bacteria. So how many want to treat asymptomatic bacteria? He has given it guidelines also when to treat asymptomatic bacteria. So this is checking your knowledge when to treat asymptomatic, because this person is going for right now the person is going for surgery, TKR. People want to check urine routine. Okay, all the PGs who registered for the thing need to answer. I'm looking for it. Maybe, still maybe. Oh, 13 messages come. Sorry, I'm not updated. Okay, 2 people want to postpone the surgery. Orthopedic surgeon will not give a reference to you. If you postpone the surgery, you will upset. Okay, so near the terminology, terminology is clearly defined. Pyuria, bacteria, what is symptomatic, what is asymptomatic. I don't want to touch upon. Dr. Muralidhar clearly covered these things. Asymptomatic bacteria, as age progresses, the chances of getting bacteria in the urine can go up. That's most important thing. And even for prostatic joint, even for the prostatic valve, there is no recommendations. He clearly told pregnant ladies supposed to be treated, urological procedures, transplants, and some other time the stones, lithotripsies, we want to break it, yes, we can. Otherwise, there is no need for giving asymptomatic bacteria for joint or heart valve surgery. Don't treat. So this is a bottom line. So this is another interesting case. What I'm going to do now? The person has got fever. The person has got body pain, weakness, but the urine routine examination is normal. What do you do? How many say this person has got UTI? Patient has got fever, body pain is there. What else is needed for UTI? People start answering. Other focus about is, yeah. So other foci people are asking. So this is a diagnosis written UTI. primary cause for the UTI. How many will agree with this diagnosis? UTI is a primary cause. There's no urinary symptoms, less likely. So Dr. Muralidhar conveyed the point. So when a person has got fever, don't think the person has got fever. The urine routine has got more value, not only for diagnosing the disease, but ruling out disease. It has got very good negative predictive value. So when a person's presents with some fever, some dysuria, vague, the symptoms is not clean, look at the urine routine. Urine routine does not show any pus cells, it rules out UTI essentially. Presence of pus cells, the chances of UTI is very high, but it does not mean always UTI. Ruling out UTI is more important with the urine routine examinations. And these things Dr. Muralidhar already touched upon, so I don't want to touch these things. So this is my last post-test question. 75-year-old male, dysuria, oliguria. Person has got 75, hesitancy is there, healthy, active, prostate was enlarged, urine routine full of pus cells, E. coli, nitrofurantoin, fosfomycin, amikacin, creatinine is 2.1. What antibiotic your choice? Dr. Muralidhar touched upon a lot of choices, lot of organisms also. So I want to check whether you grasp the knowledge of antibiotic selections. So that's why this question is quoted. This person has got UTI, probable prostatitis. What antibiotic you want to give for prostatitis? That's the bottom line I'm putting here. 7 messages. 3. I want to see this choice 3. What is 3? Amikacin they want, despite creatinine 2.1. Dr. Muralidhar touched upon sometimes the urinary tract infections increases the creatinine. So you're not bothered about 75. Urine creatinine is 2.1. So people want to give amikacin. That's a point well taken. Nitrofurantoin will not work. Fosfomycin, oral fosfomycin will not work. So IV fosfomycin, but very difficult to administer for an elderly male. So we need to think about some other options. A lot of guidelines available, but unfortunately we can't cut copy paste the Western guidelines. While I'll come back because the resistance is so much high. That's why I clearly talked about corporate sectors like us. We see a lot of resistant bugs. So we can't start norfloxacin, ofloxacin that was working well in the community 20 years back, 30 years back. Now it's not working. So we need to do the urine cultures also because we see in a corporate hospitals a lot of culture positivity. Ciprofloxacin resistance in 2000 in Chennai, it is almost 70 to 80%. That's the data we projected 20 years back. So the approach is first thing, see the severity. What sort of host? Where is the infections? Whether it's upper UTI, whether it's complicated or uncomplicated. Decide about it. Go about the symptoms. Select the antibiotics. Select the antibiotic based upon where is the source and what type of organisms you are encounter. And if source control is needed, clearly touched about by Dr. Muralidhar, remove the source. That's most important thing. Unless you do the source control, it's very difficult. For example, emphysematous pyelonephritis, I need to call my surgeon. Instead of putting meropenem, I need to call my surgeon. That's most important thing. He clearly elaborated the video. I need to thank him for showing that video. Excellent video. And talked about the cranberry juice. Yes, cranberry juice, lot of lactobacillus, or you can use curd also. Take water, apply estrogen. That can prevent a lot of UTIs. So that is most important thing. And those who want to learn more about infectious disease and algorithm, we're coming up with a good CME this month. So please enroll so that you can learn more algorithms, what Dr. Muralidhar told informed today evening. So we are going to show more algorithms for you people. Just scan and attend this mastering the ID algorithms coming next week there. So not next week, 2 weeks later. So just prepare for the thing. And now we are taking up a couple of last 2 minutes because we are overshooted the time. Just go ahead and show you ask your questions there. Anybody want to ask your questions? Unmute and ask, or anybody want to put in the chat box also, you can ask. We'll wait for 2 more minutes. Dr. Muralidhar, is fine for you? Hello?
No, I'm fine. No issue.
Yeah. So we can wait for another 2 minutes. Yeah, couple of questions can start come there. Yeah.
Sir, I have one question.
Go ahead.
So we are using a lot of phosphomycin and patient do respond, but sir was discouraging a lot. So I want to know why is not wise to use.
You'll answer.
Yeah, no, in the sense that phosphomycin, I am assuming that you're using oral phosphomycin. I'm
Yes, sir.
assuming that you're not using IV. IV phosphomycin, I'm fine because there are specific indications, there are specific conditions where we use. I'm okay. Right now, also, I have one patient, but of course, it has a lot of oral phosphomycin is not a great drug. Okay. Even though that original study where they've used 3 grams for 3 days and assumed every UTI will be cleared, is not based on a very strong science. So there is emerging evidence that when we use fosfomycin, their failure rate is very high, right? So especially oral. Nobody has figured out what is the dose. See, even in some desperate patients, I also do some jugaad and try to give for longer time, give it BD, all that based on the understanding genetics, etc. we can
But
do.
sir, I don't know
The
whether
other
I
issue
heard.
is what happens if there is somebody has,
Does it cause sodium overload? I
sorry,
don't know. Sodium overload or something you
yeah,
were.
that is IV. IV preparations are sodium based, so they can cause hyperlit.
Okay, okay.
Yeah. It causes sodium overload,
Dr. Muralidhar, couple more questions in the
not the
chat box
oral
there.
one. I'm talking about IV. Talking about IV.
Yeah. Thanks, Dr. Muralidhar. Can you have
Thank you,
some
sir.
of the questions in the chat box? Yeah, Dr. Yasmin, we'll just hold on. We'll finish the other questions and come back to you there.
Any other questions?
Role of acetohydroxyc acid in Stagon calculi, any role?
I think the Stagon calculi is a surgeon's domain. Keep it
Yes.
simple. That's what has been told to us as an undergraduate.
Yes.
I think it still holds good even after 30 years of what I've learned.
Any
I think
RCTs for
all these
asymptomatic
are
bacteria?
supplementary. All are supplementary. Okay,
Yes.
remember that.
Surgeons
Basic
told
principles
me.
of medicine, whatever I learned 30 years back, remain the same.
Any RCTs for asymptomatic bacteria in pregnancy treatment?
I can't remember off late, but there are many. I don't think so. You need to look for RCT. You can just go by guidelines because guidelines are formed based on RCTs. So, I mean, suddenly you ask me, I can't remember the code, but there are many, right? I think this is time tested data. I think gynecological and ID related both are encouraging that. So, I don't think so. We need to debate
All
about it.
guidelines written, pregnancy should treat with asymptomatic bacteria. Many RCTs there. So don't think about one RCT to quote. Now many RCTs are available. Time period of causing nitrofurantoin induced pulmonary fibrosis.
What I have not seen, so I don't have personal experience, but data I can share. It's a usually cumulative dose effect. So they're supposed to be many months. So I
Yes.
don't have experience, but one of the colleague long back I met, they're saying they had it within few weeks. I have no idea. But literature in the conferences and in the journals, whatever I've read, and in the standard pharmacology books, it's usually cumulative dose effect.
Okay.
So you give it for a little bit longer. It's not idiosyncratic reaction.
Nowadays, we are not encouraging the long-term antibiotic prophylaxis. That's other reason also. We put a short courses of antibiotics, so we are not giving 6 months to 1 year. So that's other issue. We keep on coming, so I'll restrict to last 3 there. Which is the best and safest empirical antibiotic to give UTI when culture is not available yet?
So I assume you're asking for treatment?
Yeah, empirical treatment when the culture is available.
Yeah. So I usually give cotrimoxazole, but two questions I ask before giving it, because one is it's very cheap, easily available. The only thing is one, don't forget to ask sulfur allergy. Like that girl I've told you, had I missed, I would have been sued straight away. And she's a very educated lady. Now she's nice to me, but luckily I asked and I didn't give. Second thing is renal failure. Older people, without asking for renal functions, I will never give. Probably. These are the two fundamental questions I will ask, but it's a very good drug because I found it to be very useful. Quinolones used to be a good choice 15 years back. Nowadays, I'm not a great fan of it.
Yeah,
But these
before
two you
write
should look into.
cotrimoxazole, what I do is before write cotrimoxazole, even though my standard template is like there's no drug allergy on the top, but when I write cotrimoxazole, always I write self allergy is not there. So without writing self allergy crossing, then only I can write the cotrimoxazole. So those who are prescribing cotrimoxazole, please write one word nearby. There is no self allergy. Unless you write the self allergy, you didn't ask it. So please ask it and scribe it off. That's more important. Then related to the cotrimoxazole, the cotrimoxazole resistance are increasing. They're asking, it's rising.
Yeah, just to add to what Dr. Suresh told, other thing I do is I explain that if you have a rash, because rash usually doesn't come on day one, it will come after 5 to 6 days. A lot of my Steven Johnson patients were referred to me were happened many days back, many days after treatment. So you tell them if you have rash, oral ulcer, please stop and come back immediately to me. Yeah. Of course, all antibiotics, there is drug resistance increasing, including our hospital. We produce something called antibiogram year on year, hundreds and thousands of cultures. it is increasing. Again, I reiterate what the principle is. Just because the urine is showing resistant in a uncomplicated young lady coming without any obstruction doesn't mean the drug won't work. These are lab reports which will tell you the probability of the drug working, right? If the drug is not working, they say it's resistant, so probability of not working is that it's not all or none phenomena. It is not like, oh, it will not work at all. Because you need to know these limitations. I have treated, like the first case which I told, I gave Fortremoxol. That lady did well. So I just left it and she comes after a few months with some other injury and she's doing well.
Yeah.
But she might get back again. That time I may not be able to use the drug. That's the way you look at it. So safe drug for me, that's why I said Fortremoxol is one.
Yeah.
Aplastic anemia, somebody has put, yeah, very problematic, but usually with the not the doses what we are using, biggest problem is once we go up on the dose, the big challenge is hyperkalemia. That's a big challenge. Second thing is rash, of course. As the dose increases, of course, pancytopenia is well known. But these are all dose dependent, so we can easily anticipate. We keep monitoring it. What we have done, something interesting recently is we encountered a lot of patients, especially PCP patients, prophylaxis, higher doses. We are encountering this hyperkalemia. So many times we have to look at other alternatives, and we have a lot of burden of miliar doses. We are always stuck. So what we did is we are about to publish a paper on it. I think next month it will be released by my colleague, Dr. Praveen. We have started using fludrocortisone and really works well. All of our hyperkalemia problems are solved. So mode of patients, when we give 0.1 BD, it's definitely working well. I think our paper should be published by next month. Just I think it's under review.
So since we are overshooting
That's
at
one
8:45
small
there,
tip
the
off
slides will
during
be
the
shared
talk.
there. Don't
Yeah,
worry
small
about
tip
it.
off. It'll work, but yeah,
Thanks,
this is a
thanks,
small
thanks,
tip
Dr.
off. That's all.
Muralidhar.
But be careful, hydrocortisone is not a chocolate. It has its own, yeah,
Congratulations for
it
your
has
team
its
there.
own challenges.
So I sincerely
Yeah.
thank Dr. Muralidhar as well as participants. Nearly till like a overshooting at 20 minutes, people are still there to answer and listen to the question answer. The slides are shared there because we are planning the nosocomial part. This month we are doing community syndromes. Next month we are planning to do the hospital acquired and healthcare acquired. So we can do the CAR-T part and the healthcare acquired part. We can come it up. So don't worry, but we ask the faculties to share whatever content they want to share. So definitely they're going to share at the end of the presentations. We also post it to you. So other things like people are asking about estrogen cream. Yes, estrogen cream will work there. I sincerely thank Dr. Muralidhar. In short notice, he prepared a good presentations. Unfortunately, we didn't keep the time for 1.5 hours today there, but it's a good presentations. We learned a lot of new things and a lot of advancements. He discussed about it and a lot of practical things he talked about it. Case-based approach he did. That's one of the good thing we did. And I thank all the participants and I thank ACP, APA and ICP for this opportunity. I'll ask the slides to be shared by Dr. Muralidhar soon once it is ready there. Thank you once again. Thank you once again.
Email me, I can send it back to you.
Sure, Dr. Muralidhar.
Thank you.
Thank you. Thank you
Have a
all.
great day, everyone.
Yeah,
Thank
living
you.
today.
Bye.
Thank you, sir. Thank you. Good night.
Bye-bye. Yes, निकल क्विक क्या करती थी UTI इनमें नहीं ब्लैडर स्कोर बोल रहा था तो मैं पूछो कर बचा ब्लैडर